Now we have Dr. Ankur Singh. Dr. Ankur Singh is going to present on lens-induced glaucoma or endophthalmitis, a diagnostic dilemma unfolded.
So the dilemma is already open now. Very good morning. I'm going to talk about a patient, and I want my audience to be a bit interactive. This is a 78-year-old male who presented with decrease of vision for 2 years in the left eye, with progressive painful worsening of the vision in last 2 weeks. No history of trauma or any other ocular surgery, with a history of pulmonary TB on ATT, currently for last 6 months. So look at this image. He had an hand movement close to face with an IOP of 40, diffuse circumcorneal congestion, boggy iris, hypopyon or pseudohypopyon, and a yellow glow. So what do you think is the diagnosis? End of? Probably. So what you would do? You would do an ultrasound B scan. So I did the same thing. So I did an ultrasound B scan in this patient, and I found multiple pinpoint echos with mild echogenicity. Then I looked at the retinochoroid thickness. It was okay. So because it was okay, I made a diagnosis. I made a two differential diagnosis. The primary diagnosis was lens-induced glaucoma, a lens particle glaucoma type. Still, I kept the endogenous endophthalmitis as a differential diagnosis as well. So to rule out the diagnosis, I did a UBM. Look at the UBM at this patient. Do you see the partially absorbed lens in this patient now? The one that is shown with the star. So now the diagnosis was confirmed. It was a lens-induced glaucoma, which looked like endophthalmitis initially, but the IOP was high, but it is a phacolytic glaucoma. So I managed the IOP with the IV mannitol, syrup glycerol, oral acetazolamide, topical timolol maleate. Inflammation was controlled by prednisolone acetate drops, topical cycloplegics, as well as a 30 mg 30 mg tablet prednisolone. So being a retinal surgeon by myself, I planned a 23 gauge pars plana vitrectomy with lensectomy, and I still thought, let's just keep the endophthalmitis still there, because me being a retinal surgeon, I look for endophthalmitis, not glaucoma. So I did an intraoperative, this is the intraoperative images. I just want to draw your attention to the lower third image. Look at how small the nucleus has become. This is how it was lying in the vitreous cavity with those few fluffy exudate. And this was a nucleus that was absorbed. It was, and it because the posterior capsule gave way, it came into the vitreous cavity. So what I did is then I left the patient aphakic because I was suspecting certain edema because of these lens particles sticking to the capsule. I did not remove the capsule completely. I should have. Then I did a secondary, because I thought I would put a secondary IOL in this AC sulcus that I have created. I did that, and the patient had a vision of 6/9 with IOP 14 mm of Hg and with no anti-glaucoma medication. So how I'd like to conclude is, fluffy white deposits in the anterior chamber with increased IOP is a hallmark of lens particle glaucoma. Vitreous cells presence are more suggestive of vitreous inflammation in conditions like posterior uveitis, so you would be having certain amount of retinal choroidal thickness. Endogenous endophthalmitis associated with RCT, thickness increased, but will also have KPs along with the hypopyon. And in atypical cases like this, a UBM can easily tell you that it is a phacolytic glaucoma or something else. Hemorrhagic pseudohypopyon is a feature of leukemic lymphoma or AIDS. So awareness of unconventional presentation of phacolytic glaucoma is pivotal in accurate diagnosis and optimal management. Thank you.
Very nice case. I think it was a diagnostic dilemma which you solved very nicely. Just 2 points, Ankur. Will you label it as phacolytic glaucoma or lens particle glaucoma?
Sir, lens particle glaucoma.
Lens particle, exactly. That's the point I wanted to stress on. Because phacolytic glaucoma is due to leakage of proteins from the intact anterior capsule. Whereas, there was hypopyon, there was severe anterior inflammatory reaction, which shows that lens particles had leaked out and which have blocked the trabecular meshwork, causing such great high increase in intraocular pressure. And secondly, you kept the patient on 30 milligram oral steroid.
Sir,
he was what was the weight of the patient?
Weight is 60, sir.
So 30 milligram will be, I think, slightly on the lower side, even if we gave 1 to 1.5 milligram per kg body weight.
Totally agreeable, sir. But how do we treat endophthalmitis is till we do not have a vitreous step.
We don't have.
So we give half dose of steroids.
Okay.
That's it, sir.
But you, being a retina surgeon, you brought your experience and knowledge to use to the advantage, and you did vitrectomy also,
Yeah.
and you found that the lens was totally absorbed.
And I later on did a sulcus implantation of IOL.
Sulcus implant. That was very nicely managed case. Okay.